As previously mentioned, descriptive epidemiological studies look at things like the who, the when, and the where. So for the who, we're thinking about person variables. Your textbook does cover in detail different person variables. So for example, it talks about age, sex, race, ethnicity, socioeconomic status. There are many other examples of person variables that exist, things like marital status, nativity, so your place of origin, your migration status, and religion. We're going to briefly talk about some of these variables here that are also covered in your textbook. Age is one of the most important person variables that we typically collect information on for epidemiological studies, especially when we're describing the occurrence of a disease or a health condition. This is because age-specific disease rates show really a large degree of variation and more of a degree of variation than rates defined by really any other person variable. So, for example, we tend to see large variation in terms of the burden of cancer. Cancer tends to affect people who are older more often, much more often than people who are younger. In this slide, I've got a few examples of age associations, but the incidence of and mortality from different chronic diseases can increase with age. As I mentioned, cancer is a great example of that. Certain infections are more prevalent and common the younger you are. So something like chicken pox is something that is going to typically affect young children much more often than older adults. The leading causes of death are very different across age groups. So for example, the leading cause of death among young adults is unintentional injuries, which is very different from those of older adults. And then maternal age is associated with rates of diabetes and also related complications. So we see a lot of age differences across a lot of different health conditions. We also saw a lot of age differences in COVID death rates. And we still continue to see this today. People who are older tend to be more likely to die from COVID-19 versus younger individuals. Race ethnicity is also other variables that are important in terms of person variables. The way that we typically collect these is displayed on this slide. So when we're referring to ethnicity, we are asking people whether or not they are Hispanic or Latino. If they are Hispanic or Latino, there are other options in terms of what type of Hispanic or Latino they identify as, but typically for ethnicity, we're talking about, are you Hispanic or Latino or not? For race, we're talking about racial and national origin or other sociocultural groups. This typically, when you're filling out a survey, is collected in terms of asking people if they are white, Black or African American, American Indian and Alaskan Native, Asian, Native Hawaiian, or other Pacific Islander. And this, interestingly, the Census 2000 was the first that actually allowed people to check multiple racial categories. Before that, you had to pick one, and we know that people are diverse and not everyone identifies with just one of these categories. So it was a big deal that finally changed in the 2000 census. I also want to point out that we like to classify people into these categories for research purposes. Analyzing data where we fit people into categories and into boxes makes our research analysis easier, but this is really difficult to do, especially with increasing diversity, and this can be really challenging. Some challenges with the variable race and ethnicity is that it can be somewhat ambiguous, and people can often get misclassified in terms of their race and ethnic status. It also tends to overlap pretty highly with nativity, so where you were born, and religion. And I also want to point out that this is a complete social construct. Race and ethnicity have no biological underpinnings at all. They are not biological constructs. There are no biological roots within these variables. These are completely social constructs that have been made up by society. And so people often wonder, are these really important in terms of focusing on, are there other variables related to persons that we should be looking at? However, we do use these to track various health outcomes, and we often see a lot of differences and disparities across different racial and ethnic groups. This slide shows some examples of racial and ethnic differences that have been observed in different studies. So, for example, those who identify as Hispanics actually tend to have lower frequency of asthma, which is interesting. Non-Hispanic whites and non-Hispanic Blacks less frequently report that they have no usual source of medical care than those who identify as Hispanic. We see differences in physical functioning. In terms of difficulties in physical functioning, we see that this is highest among adults who identify as Native Hawaiians and Pacific Islanders, highlighting a need to address this particular area. We also see a lot of racial and ethnic differences in terms of cancer, both incidence as well as mortality. Socioeconomic status is another really important person variable to examine. When we're talking about socioeconomic status, we're referring to a person's position in society. So individual measures of socioeconomic status tend to include things like your income level, your education level, so whether you completed high school, you completed some college, or you completed college, your type of occupation, whether you're working at a desk job versus some sort of construction job. Typically, we see that these are measured individually, so we often measure individual income, education, job status, things like that. We can also combine these into a single measure or a single dimension of socioeconomic status to classify individuals, maybe those who are under the poverty level or those who are above the poverty level. Socioeconomic status is a really important person variable to measure because we see really strong associations and relationships in terms of socioeconomic status and different health outcomes and diseases. We often see a strong inverse association of socioeconomic status with levels of morbidity and mortality, meaning that people of really low socioeconomic status tend to have really high levels of morbidity and mortality for different diseases. In the United States in particular, those in the lowest socioeconomic positions are often confronted with a large excess of morbidity and mortality from different causes. We saw this in COVID-19, especially when it came to things like type of occupation. Some people were exposed to COVID more frequently and more often than other types of occupations. There's also been quite a bit of research in this area in terms of access to dental care. And in particular, what we've seen is that children from low socioeconomic backgrounds have less access to dental care. And interestingly, that poor dental care is often associated with frequent school absences and performance. And if we think of education as being this gateway to get out of poverty, if you are somebody who is living in a low socioeconomic status household and you are affected by a lack of access to dental care, this can really compound kind of this cycle of poverty. We've mentioned health disparities in a few of these slides, but I want to make sure that you actually understand what the definition of health disparities is. So health disparities is defined as differences in the occurrence of diseases and adverse health conditions in a population. And so, for example, cancer health disparities are these adverse differences in cancer incidence, or what we refer to as new cases or cancer prevalence, cancer death or mortality, cancer survivorship, and burden of cancer that exist among specific population groups in the United States. In the US, we tend to see that African Americans and those who identify as Black, they tend to actually have the highest adjusted overall cancer incidence and death rates compared to other groups. This is typically caused by issues around access to care. There's issues around structural racism, implicit and explicit bias within the healthcare setting, but there's a number of factors that contribute to these disparities that we see among African American and Black communities in the United States.